So everybody is ready?
Yes. It's perfect.
I can start, no?
2 more minutes.
Okay.
Good evening, good morning, and welcome you all to this very interesting and pertinent topic of fingertip injuries. Thanks, Professor Jefferson, because we are the only one whom we thought of when we chose this topic. And he swiftly and immediately said, yes, we will start having this fingertip injuries webinar. Thanks, Professor, for joining us and making this event a great event to be remembered. And a lot of things we are waiting to learn from you. Apart from this eminent contribution in the field of fingertip injuries, we have 3 more speakers who also equally contributed in terms of their surgical techniques and also the concept how to manage the fingertip injuries. We have Dr. Zedenberg, Dr. Origo Burrito, and Dr. Vijay from India. So all of them are going to have a great time with us discussing about the current concepts and updates in the management of fingertip injuries. Today we have Dr. Jitendran, one of my close friend who has been working in India as a pioneer in doing all microsurgical reconstruction for fingertip injuries. So we're all happy to have the speakers and the moderators for this evening session. The program goes such a way, we will start first with Professor Jefferson Bragasilva to talk about the trauma of nail bed injury, then followed by Dr. Zedenberg, Dr. Burrito, and then Dr. Vijay will follow it. Delegates, please feel free to ask the questions in the chat box. We'll have discussion at the end because this is going to be a very common topic where everyone is keen of how to manage and what are the injuries which needs specific treatment. Thank you all for joining us. Let's hear from the first talk, Professor Jefferson Bragasilva. Thank you.
Thank you, Terrence, for the invitation. It's a pleasure to share experience with you. I work in Porto Alegre, in Brazil. I'm a full professor at the School of Medicine, and I develop public and private activities. The importance of the stem, it's in frequency and relevance in which it reaches the hand surgeon. 20% of the trauma that arrives at the emergency located in the hand, and 8% of them of the nail complex. They are usually considered by easily resolved, but there are many sequels. In the anatomy, I would highlight the nail bed and the generative matrix and the vascularization formed by branches of the 2 collateral arteries, forming the distal anatomic arch. My conference, I'm going to divide into 2 anatomical regions, nail bed and distal units, and suture of the nail bed, and the most cited article in the literature is Roser, comparison of the nail bed repair versus nail trepanation, and Magnani, controversy of the treatment of the nail bed injuries, and Fehrenbecker, the nail bed injury. The first case, extensive hematoma over the entire surface of the nail, and the right of the nail shows the extensive lesion of the nail bed. Bed suture with Vicryl 6.0, nail fixation, and result of the 6 and 25 months. An hematoma that goes beyond the fingernail, nail bed injury, suture of the nail bed, result 3 and 20 months. Another extensive hematoma, drainage of the hematoma and raising of the nail, lesion of the nail bed, and suture of the nail bed with Vicryl. Aspect of the 6 months and 22 months, and compared to the contralateral finger. The proximal dislocation of the nail raised and extensive nail bed injury is evident. Results of the 2 weeks, 3 months, 6 months, don't worry, and 70 months. You have to wait more than 12 months to have a definitive results. Result of the 70 months and the radiological aspect. Nail bed injury, aspect at 6 months, more or less, and at 14 months, you wait more than 12 months. Crushing with major nail bed injuries. Aspect of the 2 months, 6 months, 18 months, here to have a wait more than 12 months. Another extensive hematoma with significant destruction of the nail bed, stabilization and reduction of the nail bed with hypodermic needle and Vicryl suture. Nail fixation, expected 77 months and 10 years. And lesion of the nail bed and fracture of the distal phalanx. Kirschner wire and nail bed suture and nail replacement. Lesion of the nail bed, suture of the osteosynthesis by Kirschner wire. Immediate postoperative result compared with the contralateral finger. 2 traumatized distal extremities, middle finger with the extraction of the nail bed, and the ring finger with a fracture in the osteosynthesis, the nail bent proposed by Fouché. Result of 2 months, 2 beds, 3 months, 14 months. This is the preoperative view. And another avulsion of the pulp and the nail, immediate postoperative, result of postoperative view, volar view and dorsal view, and result aspect of the 45 days and 24 months, volar and dorsal aspects. Crushing of the distal of the middle and the ring finger, removal of the nail and check of the lesion, nail bed suture and osteosynthesis by Kirschner wire, and the result of the middle finger, 2 months, 4 months, and 14 months. You have a wait. And ring finger, result aspect of 2 months, 4 months, and 14 months. Here again, show the nail complex change many times for the better. Result of the 5 years. Article published by me of this topic. And the nail beds, its work? A good question. Here, in the emergence, fragment amputated from the tongue of the child of the 10 years old, with part of the nail bed. This view is thumb, part amputated and dorsal view, and volar view, the nail bed, and the result with the thumb, contralateral thumb. Significant loss of the nail bed by crushing. The hallux nail raise to remove the nail bed graft. Nail bed graft from the hallux to thumb. Result comparatively to the contralateral thumb. Here, result of the hallux of the graft, removal, preoperative and postoperative of the thumb. The final result. Loss of the substance from the nail bed, hallux graft, result at 3 months, and result of 18 months. Sequela of the nail complex, the nail bed complex, result of after excision of the ulnar side and the nail bed graft. Here, another case of non-adherent of the nail from the lack of the nail bed. Nail bed graft. Preoperative result of the preoperative and 20 months. 2 fingers of the nail bed loss and nail deformity. Graft and the result of the middle finger, 24 months, and the ring finger graft and the result of 24 months. And now I would like to talk about another subject, the nail bed regeneration. Does it exist or not? There are only 4 articles in the literature that mention of the term regeneration of the nail bed. Watch this case. Trauma of the nail bed, 1 month, 2 months, the nail bed migrates distally together with the nail, 3 months, and 15 months. The same case, huh? The same digits, okay? Severe nail bed injury, 3 months, 6, 14 months. Likewise, there is a migration of the nail bed and the nail to be distal, the result of 24 months. Another case, with the extraction of the nail bed and the aspect, the 16 months, 16 and months, 16 months. I believe that for the nail bed regenerate, it is necessary to have a volar support, a good flap, and I use atazoy and direct flow island flap. Distal trauma, atazoy flap, result of the 3 weeks. I think it's not possible to nail bed regenerated without a good flap. And 2 months and 14 months. The direct flow island flap, it's very useful, loss of the large substance, anatomical section. I don't speak the anatomical because Ezekiel talk better than me. Flap illustration. In this case, flap illustration of direct flow island flap. In this case, bed and pulp necrosis, debridement, and with dorsal and volar aspect. Dorsal view after 2 weeks and volar after 2 weeks of the direct flow island flap. Result of 3 months is no bad, so bad, and 18 months. A good result. Another case, loss of substance from the pulp of the nail bed. Maybe, could you say a distal amputation? maybe. Dissection of the island flap, placement of a distally, and 3 weeks is the result. Dorsal view and volar view, and preoperative view, and aspect 13 months, volar and dorsal, showing regenerative of the nail bed. Pulp and bed necrosis. The flap, island flap, dissection of the flap, and distal result of the pulp and the dorsal. Loss of the distal substance, made a distal amputation, axial, dorsal, and axial view. Direct flow island flap, the graft, and the dorsal, the silicone blade on the nail bed for the nail bed regeneration. 2 months, 22 months, and the result of 22. Loss of substance from the nail bed, and the result of cooperative of the finger of 24 months. And the reverse flow island flap can also be used to loss of this substance. Insufficiency of the volar and coverage cause this type of no function deformity. Reverse flow island flap, dissect and place distally. This flap will abundantly fill the loss of the substance, preventing deformity from recurring, and results volar and dorsal aspect. The result of the volar at 3 years. Another case, dissection of the flap, results in the 6th dissection of the flap, distal, place the distal part, result of the 6 months and 12 months. In this article, I published on this subject in the plastic reconstruction surgery. And when I need to reconstruct entire distal phalanx, I'll talk about conventional graft for nail unit reconstruction. Patient was a victim of the amputation of the distal phalanx of the index finger, causing enormous function and social disorders. Initially bone destruction of the performance of the external fixation, 1 millimeter for 3 days, and the external fixator. And when we have the ideal size for the functional pinch, out-shaped incision is made, and the graft composed of the nail complex of the second tool is removed. Immediate postoperative aspect into 2 months, 1 year, and 10 years. Another case, radiological aspect, the standard fixator was placed in the remaining segment of the middle phalanx, bone extraction, same technique, full-shaped incision, the conventional graft from the nail complex of the second toe, and fixation of the index finger. Aspect of the 15 days, a good integration, and aspect the 34 days, 30 and 45 days. But a 6th day, the graft nails fall, and another order appears that the aspect and sensitive and 75 days. Result of the reconstruction of the distal phalanx of the index finger and 3 years in the follow-up. This article is published in the Journal of the Hand Surgeon on this subject. I would like to take the advantage of and invited everyone of the Congress of Latin American Federation and Brazilian Congress of the Hand Surgery in December in Rio de Janeiro. Thanks a lot.
Thank you, Professor Jefferson. It was really amazing to hear the talk from your experience and then the follow-up. It was really amazing. Thanks for joining us. Indeed, we will be having a lot of questions at the end of the webinar because many of the participants, they have questions raised and all queries which we can have at the end. Your talk has opened many of the concepts, right from the aggressive way of treating the nail bed complex to a simple solutions like homodigital island flap and the reverse digital island flap, a nail bed repair, and then evacuation of hematoma. So all the basic concepts, very essential for treating fingertip injuries, are very well discussed from your talk. It was really eye-opener. Thanks for joining us. We have Jitendran, Dr. Jitendran, who will have to moderate the next session.
Dr. Zeidenberg. He is a past fellow of the CleanUp and is currently working in the anatomy department of Binis's School of Medicine and Hand Surgery Department of the Italian Hospital of Binis's. He has around 25 PubMed indexed papers, publications, and is a reviewer of GSS, AM, hand, and JHS, GO, and hand injury journals, Journal of Hand Surgery. So he will be talking today on flaps in fingertip injuries. You can start, sir.
Okay. Good morning to everyone. My name is Ezekiel Zeidenberg, and I'm going to talk about flaps for fingertip injuries. But first, I would like to thank Dr. Terrence and Dr. Bragasilva for the invitation. It is an honor for me to be a part of this meeting. Before I start to talk about the flaps, it is important to understand the blood supply of the fingers, that it is mainly provided by the proper digital arteries. These arteries are communicated through three transverse arches described by Edwards in the 60s that can be found at the level of the C1 pulley, C3 pulley, and at the distal end of the FDP insertion. The goals of reconstructions are to preserve the length and sensibility of the fingertip, to provide a durable skin coverage while avoiding or limiting nail deformities, to prevent joint contractures, and to get a sooner return to work and daily activities. There are multiple treatment options that can be divided according to the injury pattern. For patients with skin or pulp only lesions, the most common alternatives are the healing by secondary intention, skin grafting, and semi-occlusive dressing. But for patients with an exposed bone, the most accepted recommendation is to provide coverage using a local flap, such as the BY flap, cross finger flap, thinner flap, or any variant of the homodigital flaps. The BY advancement flap has been described by Erdogan Atasoy in the 70s for dorsal oblique or transverse defects and cannot be used in volar oblique lesions. It is an easy technique to perform without donor's arm morbidity, but the major drawback is the limited degree of advancement achievable of less than 1 centimeter. Another classic alternative is the thinner flap. This flap can be used for the index and long finger in a two-stage procedure that requires PIP joint flexion to bring the defect for the flap. However, this flap is associated with some problems such as finger stiffness that can result from immobilization, especially in older patients. That's why this flap should be avoided in patients older than 40 years old. And also, the donor scar on the thinner eminence can be sensitive for a long period of time. And another problem is the fact that may not provide enough bulk for fingertip padding. The cross-finger flap has been described in the 50s for the treatment of volar, transverse, and oblique defects. It is also a two-stage procedure in which the recipient digits needs to flex at the PIP joint for inset and is thus at risk for stiffness. This is a case example of a patient with a volar defect of the ring finger secondary to a severe infection in which we use a cross-finger flap as a treatment. First, we design a rectangular flap on the dorsal aspect of the long finger, keeping intact the peritenon to provide adequate coverage of the volar defect of the ring finger. And finally, we cover the donor side with full thickness skin graft, and this was the outcome 1 year after surgery. Another option is the antegrade homodigital flap. These flaps is used for volar, transverse, or oblique defects. The main advantage of this flap over the previous one that we mentioned is the sensibility obtained that, according to some studies, the 2-point discriminations range between 3 to 5 millimeters. But as a PIP joint is needed to facilitate, PIP joint flexion is needed to facilitate the distal mobilization of the flap, is associated with PIP joint contractures. This is a case example of a patient with an oblique defect in which we decide to use an antegrade homodigital flap. And as you can see on the drawing on the left, to get an appropriate advancement of the pedicle, the connected branches between the proper digital arteries need to be ligated to get the maximum advancement possible without flexing the PIP joint. The Pulp exchange Plasti is a variant of the antegrade homodigital flap and is indicated for defects involving the dominant hemipulp. This flap is a translational flap rather than an advancement flap. And this is a case example of a patient with an amputation on the radial side of the index fingertip, in which the Pulp exchange Plasti was used to provide coverage of the dominant side of the index finger. The retrograde homodigital flap is indicated for larger volar, transverse, and oblique defects, and is based on the interconnections between the proper digital arteries, especially at the level of the C3 poly. This is a video of the surgical technique of the retrograde homodigital flap. We designed the flap according to the defect, and we use a mid-lateral approach and proceed to the dissection of the pedicle. The skin paddle can be designed on the volar or dorsolateral aspect of the proximal phalanx. Once the proper digital artery and nerve are identified, we carefully release the dorsal branches of the artery to allow adequate mobilization of the pedicle. And then we continue the dissection distally until we found the connected branch to the contralateral artery that is going to be that's going to provide the vascularization of the pedicle. That's the Edwards anastomosis. At this point, we complete the dissection of the skin paddle with a careful coagulation of the bleeding vessels to avoid an hematoma around the flap. Then we release the artery from the nerve, always taking care not to damage the arterial skin perforator of the flap. And once the nerve has been completely released, we ligate the artery proximally, and then the flap can be mobilized to the distal defect. This is a case example of a 51-year-old female with an volar oblique amputation with an exposed bone, in which we use the reverse homodigital flap with the technique that I previously showed. And this was the outcome 2 weeks after the procedure, where we allow full mobilization of the finger, and it was the result 5 months after surgery. This is another case example of a patient with a dorsal defect, an exposed tendon without peritoneum, in which we use the homodigital reverse flap with adequate intraoperative vascularization and complete healing 5 weeks after the procedure. As you know, Dr. Bragasilva et al. Published this really interesting randomized prospective study comparing the reverse and direct homodigital flaps. And they observed that the direct or antegrade flap show a sensation close to normal with a simple procedure and with minimal donor site scar, in comparison with the reverse group that show less sensibility but better range of motion. Trying to solve the problem of the lesser sensibility provided by the retrograde flap, some authors recommended the use of the resensitized reverse flap. The flap design is the same, but instead of release the nerve, in the resensitized flap, the digital nerve is cut in the palm and sutured to the contralateral nerve stump. This allowed to have a flap with a larger arc of rotation when compared to the homodigital direct flap, and better sensation when compared to the non-sensitive reverse flap. The dorsal homodigital flap is another alternative, but in this case is supplied by the dorsal digital arteries and designed on the dorsolateral aspect of the proximal or middle phalanx. It needs to be 10 or 15% larger than the defect to avoid contractures. This is another case example of a 45-year-old male with an oblique, volar oblique amputation, in which we use this flap with these outcomes 3 months after surgery. And this is an interesting paper published by the Kleiner-Kutz Institute, where they compare the outcomes of 18 homodigital dorsolateral flaps and against 9 cross-finger flap for Pulp defects. And they found better sensibility and better range of motion at final follow-up in the dorsolateral flap group. Over the years, there has been controversy whether to amputate or replant a fingertip lesion in Tamizon 1. This paper, published in the Journal of Hand Surgery in 2019 by Nakanishi et al., compared the outcomes of 23 patients treated by Reconstruction using a digital artery flap against 14 patients in which replantation was decided. The DASH score didn't show significant differences, but the patients in the digital artery flap group gave better objective functional outcomes than microsurgical replantation in terms of strength measured by key pinch, digital sensibility, and finger mobility. But probably the most controversial topic nowadays regarding fingertip reconstruction is the extended indication of the semi-occlusive dressing. Some authors, including Donald Lalonde, have been using this treatment even for patients with an exposed bone. In 2014, in the European volume of the Journal of Hand Surgery, a report of 14 patients with fingertip amputation and exposed bone showed regeneration of soft tissue thickness to almost 90% of its former extent and an average of 2-point discrimination of 4 millimeters. But up to date, there is still lack of conclusive comparative data to decide between these two alternatives. So in summary, fingertip reconstruction should optimize digital motion, sensation, and aesthetics. We need to understand the pros and cons of the multitude of options for reconstruction, and the ideal reconstruction produces a sensate, well-padded fingertip. That's it. Thank you very much.
Thank you very much, Dr. Zeidenberg. That was a good talk. The controversy regarding the occlusive dressing and the flap will be discussed later. The next talk is by Dr. George Beret. Dr. George Beret is a board-certified orthopedic and hand surgeon. In 1999, he began his training in orthopedic and traumatology. In 2004, he continued his training with a 2-year fellowships specializing in hand and upper limb surgery at the Hospital Italino Buenos Aires. His training continued in France in the Leporini University Hospital in the city of Montpellier, where he acquired training in peripheral nerve and brachial plexus surgery, as well as obtaining a university diploma in microsurgery. Back in Argentina in 2007, Dr. Burrito joined the hand and upper extremity surgery department of the Hospital Italino Buenos Aires, where he currently developed his practice of hand surgery, reconstructive microsurgery, and brachial plexus surgery. His activities in different scientific societies of the country and abroad has allowed him to serve as Secretary General of the Argentine Association of Hand Surgery, Deputy Editor of the Journal of Argentine Association of Orthopedics and Traumatology. He is a member of the editorial board of Journal of Hand and Microsurgery, as well as a professor in the Argentine Association of Hand Surgery and American Association of Orthopedic Surgeons. Currently, Dr. Burrito is the author and co-author of more than 50 articles published in peer-reviewed journals, indexed in PubMed, and several chapters in orthopedic books. So he'll be talking about partial grade toe transfers for fingertip reconstruction. You can start, sir. Dr. George Beret.
Hello, everybody. It's a pleasure to be with you. And thank you so much, Terrence and Jefferson, for your kind invitation. Well, as you know, my talk is about partial grade toe transfer for fingertip reconstruction. And the main function of the fingertip is to perform the pulp-to-pulp pinch to accomplish this function. Sensibility and stability of the pulp are the key properties. Sensibility of the pulp is provided by the division of the palmar digital nerve, but the stability of the fingertip is provided by different structures. Apart from the skeletal support, the stability and control of the deformability of the pulp are provided by the fibrous structure of the pulp. Differences in this structure make it possible to distinguish between a proximal and a distal pulp. The radial arrangement of the pulp, of the distal pulp, and the fibrous septa of the distal pulp provide stability and resistance to deformation. Finally, the last element involved in the stability of the distal pulp is represented by the nail plate itself by doing a counter pressure. Traumatic finger amputation produces not only loss of aesthetic, but different degrees of loss of function, even in fingertip amputations. As Ezekiel said, the goal of treatment of any injury fingertip should be restoration of a stable interface for object manipulation while looking as normal as possible. The pulp should be stable and pain-free, and the nail plate geometry should permit the manipulation of small objects. Treatment of fingertip amputation is best performed by replantation because of the lost structure are restored. However, most of these injuries affect partially one or more structures of the fingertip, and the treatment should address a complete reconstruction defined patient by patient. Local flap, such as the ataxoid flap, when correctly indicated, yields good results. At our department, as Ezekiel said, homodigital flap, either with direct or reverse flow, are the main indication to reconstruct more extensive pulp defects. However, some patients, because of a failed treatment or the lack of treatment, suffer different degrees of nail deformity, or what is even worse, they suffer for a complete loss of the fingertip. Since some years ago, and due to the development of the technique, microsurgical reconstruction has been described and recommended by different authors to deal with these sequels. Even if the second choice is the main indication to reconstruct the fingertip injuries, the patient has several complaints regarding the appearance, mainly because of the tip of the second toe is bulbous and the nail is short. To overcome with this disadvantage, several refinements has been published to improve the final aesthetic result. In the study of Xiao, they describe 3 steps to improve aesthetic of the second toe. In the first step, they harvest and insert a great toe keyhole flap into the volar side of the transferred second toe to provide fullness in appearance. The second step is to excise the eponychium to give an apparent lengthening of the nail, and the third step is to perform bilateral elliptical excision in the pulp to reduce the bulk of the tip of the second toe. This is a key example of the Xiao publication with the techniques described by them. However, even if the second toe could be improved aesthetically, morbidity of the donor side remains, either by losing the nail plate, as in case of the second toe nail transfer, or a shortened second toe with an amputation stab, as in a case of distal second toe transfer. To address the aforementioned disadvantages of second toe transfer, we sought an alternative procedure that would allow us to perform a fingertip reconstruction with the light principle, as well as minimize donor side morbidity. So we decided to address these cases with a partial transfer of the great toe in order to not only to reconstruct the missing part of the fingertip, but also to minimize the morbidity of the donor side by resection just partially the nail plate. Some example cases. The first one is a case of a 53-year-old woman who suffered a fingertip amputation of her dominant long finger 9 months ago. Her main complaint was cosmetic. She had good function of the finger, even in the remainder base of the distal phalanx. During the preoperative planning, a great discrepancy in the length of the nail plate was found between the second toe and the contralateral long finger. So, a partial great toe transfer was planned to improve the length of the nail plane in the reconstructed fingertip in order to mimicking the contralateral long fingertip. During the operative procedure, the dorsal vein are first identified and the plantar peroneal artery are identified secondly by a retrograde dissection. The length of the artery harvested from the foot should be enough to perform an end-to-end suture with the recipient finger digital artery at the level of the second phalanx. Fixation of the composite flap is performed with cow wires, which remains until bone healing. These are the results of the recipient and donor side. A good match of the nail plate of the finger was achieved. Although some hypertrophic scar of the donor side was developed, all the toe have complete length and nail plate. The second case is about a 25-year-old woman who suffered a traumatic amputation of her less long fingertip 20 years ago. In this case, an osteonicocutaneous flap was harvested without a nail matrix. At 9 months follow-up, she had functional motion of the distal interphalangeal joint with no deformity of the nail and an excellent cosmetic result of the donor side. The last case is about a 26-year-old woman who suffered amputation of her right fingertip 1 year ago. At the time of amputation, a VY flap was performed elsewhere. Again, the main complaint of the patient was cosmetic. The partial great toe transfer toe flap was harvested and inserting in the index finger. Primary closure of the great toe was performed. These are the results on the donor and the recipient side at 3 months postoperative. In summary, the partial great toe transfer is a versatile reconstructive option that allows treating different defects in finger. Customization of the transfer achieves reconstruction in three-dimensional defects, resulting in good contour and aesthetic. Reconstruction of the finger from the great toe avoid loss of the nail complex of the second toe with minimal morbidity of the donor side. Thank you so much.
Thank you, Burrito, for your excellent talk. Very amazing to see all your
You're welcome.
pre-operative and post-operative pictures, and we definitely have an idea that all fingertip injuries may not need a reconstruction with a free pulp or a partial toe transfer. But then the indications you have mentioned are really very pertinent and essential for the patients who need the fingertip to be pulp sensitive with nail bed, and also to maintain the length which essentially they need at the end of the day. Thank you very much for your interesting talk on this webinar. We have questions, and we'll post at the end of the discussion. Yeah. Next, we have Dr. Vijay from India. He doesn't need more an introduction, because he's a man of more innovative techniques. Has been here with us in the Indian Society of Hand Surgery. He's been doing a lot of wonderful surgeries, especially in fingertip injuries, and he has invented his own technique, which is published, and motivated many Indian surgeons to try and get his techniques and pass across to treat the fingertip amputations. So thanks, Dr. Vijay, for joining us. We actually we have him as the last speaker, because that's a way that we want to get the hang of the entire presentation from the pioneers, followed by the new innovative techniques by Vijay. Vijay, go ahead, Vijay. Thanks.
Yeah, but I'm not sharing my screen, because problem is that both the laptops are hanged, and I'm conducting from iPhone. So there is no option. Where is the option? So can I share the content? Share the screen. Start podcast. Yeah, I'm sharing the screen. Can you see my screen?
Yeah. Go ahead.
Okay. Can you see this presentation?
Yeah, perfect. Go ahead.
Okay. So today's good evening, everybody. Today's topic is graft reposition on flap, because it is basically 8 years back I read the paper of Bragasilva, and I have opportunity to present this paper in front of him, because I first read his paper about destruction osteogenesis with free nail bed graft, published in the Journal of Hand Surgery, and then I started this reconstruction of the fingertip. So my today's topic is graft reposition flap. So hand is highly specialized organ and considered the second eye of the body, which is classically shown by the solidarity, the hand and the eye picture. So fingertip injury is commonly treated by general physician, general surgeon, orthopedic surgeon, plastic surgeon. But how different we as a hand surgeon deal with? So different presentation of fingertip injuries. There are no one injury is the same by other. What are the expectations of the patients? First expectation is the nail. The second is the finger length, osmosis, sensation, and return to work. So everybody knows the Allen's classification. Type 1, 2, 3 is easily reconstructable and gives a good cosmetic and functional result. But the problem is the type 4 amputation, where it's amputated from the at the level of the lunula, distal phalanx and pulp loss, and it is very difficult to treat. So ability of the amputation describes dorsal oblique, transverse, and volar oblique. So there is no uniformity regarding to the best treatment of the fingertip amputation, because the evaluation of the published result is problematic. To match the need of the patient is the need of the debate. So basically, there are the type 4 amputation. Lot many has been spoken. Replantation is the most effective treatment. Then composite graft, revision amputation, reposition flap, local distance flap, toe transfer, and free flaps are described for Allen type 4 amputation. So what is different? This is graft reposition on flap, where the reattachment of the bone and the free nail bed separately covered with a local flap. This is published in 2015 in Journal of Hand Surgery. What is the principle of GRF? The principle of GRF is increasing the area of the contact with a vascular bed is known to increase the survival rate. So when to do GRF? If amputation is distal to the lunula, no need to GRF, because basically in type 1, 2, and 3, the bone support is more than 50%. So there is no need of putting a bone back because it will give a good nail support and nail will be fine. But the problem is beyond type 4 amputation, where the less than 50% support is there. So the bone support is important. So we do GRF in type 4 amputation. What are the indications? Only one indication is the type 4 amputation, but if it is severely crushed or non-replantable, failed replantation and failed composite graft, where the germinal layer should be intact. The aim of the study was to analyze the outcome of GRF in type 4 amputations. We treated retrospectively, analyzed the 30 fingertip amputations between 2012 to 2020. 26 were male, average age was 30 years. Inclusion criteria was type 4 amputation. Exclusion criteria was 1 to 3 amputation. Ethical committee was approval is given. So right side is involvement is more. Index finger were 10, followed by thumb, middle ring, and little finger. 29 were crush amputation, 16 were industrial, and 13 were domestic. 27 were acute, and 3 patients presented to us in delayed phase. None of them were smoker. All patients brought amputated fingertip. The technique we do under supraclavicular block, it is a daycare procedure, and this is the link of the YouTube where his video is demonstrated. And this is a small video of this technique, 2 minutes. We first do a separation of nail plate. And pulp tissue is removed from the remaining bone and the nail blade. The full thickness nail bed graft is harvested from the nail bone. And first we do the multiple drilling of the multiple drill to the bone to increase the perfusion. Then we do the meshing of the nail bed to increase the surface area of the nail bed. Then we prepare the stump by elevating the nail fold. Take out the little nail bed to expose the bone edges. Then fix that bone, free bone, by 0.8 mm K-wire or 21 gauge needle to the proximal stump. The suturing of the nail bed as a nail bed graft by 6/0 catgut. Depending on the geometry, we cover with a thinner flap, cross finger flap, or via Plasti. Here we cover with a thinner flap because it's a volar defect. We do ring cut modification. The flap is more lateral, away from the gripping area. Then we do a primary closure of the donor site. Then anchor suture to fix the finger. Then flap insetting, 2 sutures on each side. We suture a nail bed to the tip of the flap by 6/0 catgut. We reposit the nail plate and suture the flap to the flap to prevent air drying necrosis. This is the final construct. Protect with a POP slab for 2 weeks. After 2 weeks, we divide, and this is 1 year follow-up. Good cosmetic appearance and good pulp contour with a transfer of thinner print. So this is the case 1, thumb bike chain injury. GRF has been done. This is the 5-year result. with a good nail and pulp contour, and there is a good consolidation of the bone. And another second case, bite chain injury, thumb. This is 5-year result with a good nail and pulp with the healing of the bone. Then case 3, industrial accident, is the index finger. This is a 5-year result. Then another long finger, bite chain injury, again 5-year result. See the full flexion of the DIP joint. Then the thinner flap is away from the gripping area, scar. Then case 5, ring finger, 5-year result. Then the case number 6, small finger, 5-year result. Date presentation of the amputation, this 15 days old somebody has reattached as the composite graft came to us, and we did a GRF where we use a nail bed graft from the middle finger, and this is 1-year result. And this is a 6 weeks old fingertip amputation. Patient has kept that fingertip amputation in his pocket, thinking that it will be useful in future. I don't know why he has kept it, but this is what he has given me answer. So we did a GRF, delayed GRF, where if you see when we debride the fingertip, the bone was not blackened. It is showing a good color. So we put it back, then do a nail bed grafting from middle finger and fix with a K-wire. And this is the 1-year result. This is published in recently in 2021 in the Journal of Hand Surgery, where we see the good nail pulp and donor area also, nail is also good. One complication was nail bed necrosis, but you can easily counter by doing a nail bed grafting. This is 5-year result. So why there was a nail bed grafting? We did a peripheral angio with a thinner flap in situ to see how is the blood supply, and we see that the vascular supply to the bone is there from the base, and it supplies the bone. So we get nourishment from the flap. So this is the after 2 weeks. If you see carefully, the nail bed has been showing some vascularity. It is vascular. So for this, we do a technical modification. The separation of the bone and the nail bed as a free graft increases surface area, and the drilling of the bone increases the perfusion of the nail bed from the flap by plasmatic imbibition. So that's why we do drilling, and the meshing of the nail bed again increases surface area for take-up of the nail graft. Reposition of the nail plate in the nail fold is a very important step to avoid the necrosis of the nail bed by air drying. So these are the results. The geometry of amputation was most common was the transverse amputation. Then local flap, we used 16 cross finger flap, 9 thinner and 5 VY Plasti. Follow-up was 1 to 5 years, 2.5 years was average. Nail appearance 87% excellent. 4 had small or thick nail due to the nail bed necrosis. It was because of the initial infection. Shortening was average 5.2 millimeter. Wash score was 0, and 2 PD was 5.8 millimeter. Aroma at PIP and DIP was full. No donor side problem. Cosmosis, 4 skin color mismatch was there. So they were worried about that cosmosis. None had cold intolerance. And this is the chart of the 2 PD. VY was 5 millimeter. Thinner was 5.57, and crossing was 6.8 millimeter. In discussion, for type 4 amputation, replantation is the gold standard, but it is not always possible because it requires microsurgical expertise. Then second reconstruction was described as nail bed grafting and the flap, local or regional, without a bone support, but the hook nail deformity is the problem. Revision amputation, again, there is the absence nail or shortening of the finger. Then in literature, the reposition flap has been described, but the Dubras series showed that 100% claw nail. Bragasilva shows that the 20-degree extension deposit PIP joint. 2PD was 8 millimeter. 80% bone consolidation, and cold intolerance on 84% in Roberts et al. Series. So in our series, 100% consolidation, no pulp tenderness. 2PD was 5.8 millimeter. RMA was full. no finger stiffness, no donor site morbidity, no cold intolerance, shortening was 5.2 millimeter, good cosmosis, return to work, overall good subject to satisfaction. So this is the algorithm of the Allen type 4 amputation. So if you, first is replantation, if it's successful, it's normal finger. But if it is failure, then again we do shortening and closure. Other options, shortening and closure, flap cover, unfavorable result, hook nail or no nail. In GRF, as good as normal finger. Limitation, it is a retrospective study, small series, incorporation of the nail bed to the flap and the bone needs better understanding by histochemical analysis. Large prospective study is essential. In conclusion, GRF has proven to be simple and reliable procedure, and it can be done by a well-trained resident or fellow in the hand surgery. Not required skills to perform like microsurgery. GRF is recommended as a technique for Allen's type 4 amputation and emphasizes its viable role in reconstructive procedure. So imagination is more important than knowledge. Imagination is the language of soul. Pay attention to the imagination. You will discover all you need to be fulfilled. Stay home, be safe. Thank you very much.
Thank you, Jane, again for your wonderful talk on your favorite topic of type 4 Allen amputation. Those are really amazing, and we have a lot of questions to the panelists. The common question to all the panelists is, I've read the article of Dr. Gunther German, where he says that there is a shift of treatment modalities from surgery to conservative. Few of the European surgeons here would agree or disagree to the view that conservative treatment, semi-occlusive dressing, does well the job at the end of the day. Probably we'll get the thoughts from Dr. Bragasilva and the other panelists. Is there a change in the paradigm from surgery to conservative? Yep, go ahead.
I don't know. Change the paradigm. I don't know. I think the nail bed regeneration is it's a good option for the reconstruction of the fingertip, but you need use a good flap, Jefferson flap or Island flap, direct flap. If you wait 12 months, 14 months for the results, I think it is necessary to understand this concept of the regeneration of the nail bed and a good flap for the volar aspect. I think it's very important.
Dr. Borito?
I have no experience with the semi-occlusive dressing. I think that it's, well, the literature show that is a reasonable option, but I don't know. We are reconstructing a very important structure with a scar. So, well, if the pulp is regenerated, yes, we can see the picture in the papers, but I don't know the quality of this regeneration. I have no experience, and I prefer the operative option.
Thanks. Before moving to Jitendran, Dr. Zadenberg, your comments on semi-occlusive dressing, and where do you recommend these dressings in your practice?
Well, I think that's a really controversial topic because if you ask most of the European surgeons, they are going to recommend the semi-occlusive dressing, and if you talk with an Asian surgeon or probably South America, they are going to go for flap reconstruction. And I believe that truly the real indication is probably in the middle of it. So and it is not clear in the literature nowadays. Because not all fingertip lesions can be treated with an semi-occlusive dressings, and I can argue that. But obviously, I think that that's true. Not all amputations need to be treated with a flap. But probably, I believe that amputations, as I said, with a volar oblique, with a minimal exposure of the bone, may have a reasonable outcomes with a semi-occlusive dressing, and I think I don't do it in my daily practice, but I believe that other opinion of other surgeons, and I read the publications that says and report the good outcomes. Probably that will be my opinion. I'm not convinced about more severe amputations are going to work with semi-occlusive dressings, but definitely can work for skin, pulp, or even for a bone with a minimal bone exposure.
Yeah, thanks. Jitendra?
Yeah. Per se, we don't offer semi-occlusive dressings in our setup. Okay. But if there's enough pulp which is available without much of bone exposure, I think it may work for some patients. Yeah. But not for every patient, it may not work. But people who are ready to wait for some more time and who are not ready for any surgery, then it may work for them. But per se, and the experience is very limited because we are not offering them semi-occlusive dressings as such.
Yeah. Thanks, Jitendran.
It's very difficult for the patients. Very difficult for the patients. I think it's. I don't use.
Yeah. Thank you, Professor Jefferson. The other question to the panelist: in cases of your, this question is from Dr. Bharat Kadadi, especially to Vijay and other panelists. See, you're going to reconstruct a fingertip injury that is badly crushed. Say, for example, you don't have a bone to reconstruct. Where would you take a bone graft?
From radius we can take radius styloid.
Does all your reconstructive surgery did not need a bone graft, or in what situations you think you need a bone graft to support the flap or to support the nail bed?
As shown in the presentation also, if the nail support is when the bone loss is more than 50%, usually in Allen type 4 amputation, it requires bone support, because if 50% less than 50% bone support is there, there has to be a hook nail deformity. If it is more than 50%, you cover more than 50%, usually in type 1, 2, and 3 amputations. Then there is no need of putting the back bone, and only flap and nail bed grafting is enough. But if it is a type 4 amputation, at the linular level, then it requires bone support.
Thanks, Vijay. Thanks, Vijay. Any comments from the panelist? In what scenario really think that you need to have a bone graft?
I use the reposition flap for the conventional technique. You have a conventional of in urgencies of Monteiro, described as the 2 weeks after the trauma. You remove the necrosis and you make the flap. But with Fouché, you publish the series of the Guy Fouché, and the results are good results. But I have in Porto Alegre cold intolerance. It's very, very frequent. It's very, very bad for the patients. But I don't have I don't use the bone graft. I use the graft of the part amputated.
I haven't used the reposition flat so much, and I have a question about that. Probably for Jefferson, because this concept is a concept of Fouché about the distal bone graft, the distal bone graft. How, in your experience, Jefferson, how many patients have resorption of the bone graft, of the distal bone graft?
Yes, it's very important, George, because I think the better result for me is the Island flap, not atazoy. Because the Island flap is a good flap. The bone, the reposition of the bone with a good flap in volar aspect, for me it's better. Because the atazoy or the cutler is not good for the reposition. The better result for me is a Island flap. And absorption of the bone is more frequent for the technique of Monteiro technique. Monteiro technique is the reposition. You attempt in 2 weeks, remove the necrosis, and make the flap. This is osteitis. It's a great patient of the osteitis and the resorption of the bone.
Another question is
of the bone. I think the resorption of the bone is equal a flap. You know.
Yes, I understand. Thank you. And another question is about what about the nail bed, because the nail bed is over the non-vascularized bone. So with the flap, you revascularize the bone, but how long take the revascularization of the bone to revascularize the nail bed? So is there a necrosis of the nail bed graft?
So for first of 2 or 3 patients, we face this problem of necrosis, because the problem was we didn't put a nail plate, and we put a nail plate, and every dressing we just take out the nail plate and see where that the nail bed is healing or not. But after 2 to 3 patients, we decided not to elevate the nail plate unless and until it is wholly healed. So we never, then after we never take off the nail plate to see the nail bed, and that's why we switched it to the flap, and it takes around 1 month, 1 to 1.5 months to revascularize the nail bed and form a thin layer of nail on top. And what happens when the new nail comes? Automatically the deposit nail gets loosened and it's thrown up. So this is the stage where the nail bed is healed, when the nail plate is loosened. So then only we remove the nail plate.
Okay, thank you so much.
Jorge, is one comment about your question about resorption. I believe that there is not enough experience in the literature regarding the resorption of the distal end bone graft in fingertip reconstruction. But if you check the outcomes on osteoplastic reconstruction of the thumb, you can clearly see the resorption is there. And then I have another question: is what do you think about the use of a vascularized bone graft in that case? I mean, do you consider the vascularized bone graft a reasonable alternative, or do you think that's an overkill for a patient that may
basically if you see the fingertip is a cancellous bone, and any cancellous bone will get a collapse. That's why in distal and radius, there is always collapse and healing. So it have, because any bone graft you put, cancellous bone graft you put, there is always collapse. In our series also there is a 5 millimeter collapse is there, shortening is there. And if you putting a vascular bone graft, that means you are killing the mosquito with a gun. Because if you putting a we have got a nail bed bone, and we are putting it with a vascular with a flap, and it gives a very good result. So why to go for a very ghastly procedure for a tiny little fingertip? So I don't think vascular bone graft. I don't have experience, but I will not prefer, because it's a very simple procedure. So I don't use vascular bone graft. I don't think so.
Thanks, Vijay. One more question to the panelist. Is the use of groin flap or the abdominal flap become obsolete in fingertip? Because you surgeons have been, doing a lot of island flaps, reverse island flaps, partial to position on flap. So many reconstructive options are there. They have produced excellent outcomes in terms of possibility. One of the delegates want to know: any of you used in your practice groin flap or an abdomen flap for any fingertip injuries? Because do you think it has become obsolete, or does it have any role?
I don't use. No, never.
No from me.
We use quite commonly for fingertip injuries. Whenever there's extensive pulp loss, we will be using a pedicle flap for coverage, and later dividing and later thinning it out. It works well. There's no problem about it.
Yeah.
Whenever there are no local options possible, we'll use a distant pedicle flap for it, instead of using a microvascular technique to reconstruct, because many of the patients will not afford a microvascular technique to be done. So we will be doing a pedicle flap. Anyhow, it's a matter of 3 weeks down the time. And after that, whether it's a microvascular or a pedicle flap, it's almost the same. Basically, the microvascular technique is to give the blood supply to the skin so that it survives. Here, the patient is keeping the position, and the flap is getting insert on the fingers.
Thanks, Jitendran. The message to be delivered to the delegates are: there are a lot of good reconstructive options for fingertip injuries. Your attocyte flap, your PY flaps, oblique flap fraud of Swami and Subramaniam. We have many other reconstructive flaps, like even a cross finger flap, homodigital island flap, a reverse island flap. So many reconstructive options are there in addition to the graft reposition flap. Preferably, you need to have, as Dr. Burrito said, a like for like. Probably these reconstructive options give the like for like reconstruction, and we don't prefer nowadays the option of having a distant flap like a groin abdomen flap. The message is very clear to the delegates. So I think we had nice discussion during this interesting webinar. To close this webinar, great is the art of beginning and greatest is the art of ending. So we'll have a close, quick comments, 30 seconds comments from Professor Bragasilva, Burrito, Zerenberg, Vijay, and Jitendran, and probably we'll call it a day.
For me, it's a pleasure to participate in this webinar with you. And I think the fingertip injuries is very, very common, very frequent. It's very, very, you have many patients with sequelae. because I think it's very sample for the treatment. Maquetation of the nail bed, of the nail, of the pulp. It's not complicated for treatment of the emergencies. And the sequela is very difficult to corrige. It's very, very difficult. And I think it's, for me, is important for the treatment in urgence of the fingertip. It's very important for me.
Thanks, Professor.
Yeah.
Dr. Burrito?
Well, first of all, I want to thank you, all of you, especially you, Terrence, for the invitation, as well as Jefferson. He always pushed me up for work, and it's a pleasure, Jefferson. It's always a pleasure. As I agree with Jefferson, that probably the best moment to treat these injuries is during the urgence, because the complication and the sequels are very difficult to treat and not always with good result. So I think that we have to choose the different option we saw today according to the patient, and most of them according to the injury we have. So I think that every flap has their own indication. As Jefferson said, the most important thing to avoid a hook nail, apart from the length of the skeleton, is to avoid a short flap. A flap who is short is a flap who allows a hook nail deformity. So this is very important, and I think that in this type of injury we have a lot of options, and more simple. One of them more simple. The others more complicated, more complex procedure. But we have to choose the right procedure for the right patient.
Yeah, well said. Thanks, Dr. Zeidenberg.
From a scientific point of view, I believe that we need more comparative data, as I said in my presentation, because when you read papers about flap reconstruction, everything seems to work, but really we need to be to have like a more deeper analysis of the patient injury patterns, surgeon's experience, and several other factors that are usually underestimated in the literature. So I believe that not everything is the same, and we need more like good data to compare the different flaps. From a personal point of view, I would like to thank again you, Terrence, and it is an honor for me to be a part of this meeting with Dr. Bragasilva, that is a pioneer on this topic. So also with a friend like Jorge or Vijay, thank you.
Thanks, Dr. Zeidenberg. Vijay?
Yeah, first of all, thank Terrence to giving me to speak in front of giant Bragasilva, because I'm very fan of his. Because first I read this paper for reposition flap by Fouché, and then he has written a very good paper on reposition flap also. So it's very honored for me to share this webinar with him. And apart from this, all this thing for fingertip amputation is my very favorite topic. And previously, type 4 amputation, there was always shortening and closure. The patient wants nail, because every patient, first question asked when there is an amputation, what about my nail? Is the first question of every patient. It's from India, from Argentina, or Europe, Australian. Every patient wants a nail. And by this technique, because by this technique we can give a nail back, and replantation for every center and every surgeon is not possible. There are many factors, socio-economical, educational, expertise. So this option of reposition, GRF, opens the new gate for the surgeon who don't know about microvascular surgery, and still they can give a good sunset flat finger and good nail to the patient. And if by this webinar one the who are attending this webinar does one fingertip and save the one fingertip, then this will be the most important, what you say, a million, you got the uh, purpose of this webinar. So thank you, Terrence, and thank you for other panelists, Edinburgh and Borito, and thank you all.
Thank you, Jay. Muchas gracias. Jitendran?
Yeah. See, in our setup, what we see is that most of the patients will come either for a nail deformity or for loss of nail. They always want the nail to be reconstructed. They always come and ask. If they don't have the germinal matrix also, they will come and ask, we want a nail to be done. Do anything but get us a nail. So nail, the paper mentioned in which the free nail bed graft along with the germinal matrix is transferred from the toe. That also is a very good option for people who want to reconstruct the nail. And nail bed grafting on the bone, as described by Vijay, that also we are following, and we have good results with that also. And in many cases, we are just doing the flap with the nail bed graft. That also gives good result. If the bone, if we have adequate bone support, we don't have any deformities as such. But per se, nail bed, this fingertip injuries is neglected quite a bit in our country, because most of the people, they consider it as a trivial injury, and people don't seek good attention or a good treatment. So they end up with deformities, and once they end up with deformities, they do come to us for correction. Secondary correction is always more difficult than the primary surgery.
It was a nice webinar with loads of interesting knowledge and updates. Thanks, Professor Jefferson Bragasilva. As many of us wished to have you in this fingertip injury, especially we can't think any person apart from you to suit this injury. Your experience counts a lot. Apart from your surgical technique and the current updates or controversies, you update your experience counts a lot. And thanks for the pertinent fact of reconstructing fingertip injuries. Rightly said, Dr. Borito, like reconstruction, of course, their day, it's the day and it's the hour of thinking, like reconstruction. Dr. Edinburgh, a wonderful, explanation about the lack of scientific data in the current literature, because you look at the literature, you have different types of treatment, and each authors claim that they are doing well. It makes the author, the readers, to choose which technique. Vijay, wonderful about your Plasti. Jitendran, great moderator. Overall, at the end of the day, choose your patient, treat wisely, and get the finger back to work with a reasonable functional outcome. Thank you, one and all. Wishing you all safe and healthy at this juncture. We'll hope to meet you all soon. Stay safe and thank you. Bye-bye.
Thank you.
Bye. Thank you. Thank you. Thank you all.
Bye.
Ciao.
Thank you.
Bye. Thank you.
Bye. Good, yeah.
It was nice, huh?
Thank you.
Yeah.
I'm just going to wind up so that the YouTube will get closed. Thanks. Thanks.
Yeah. Okay, bye.
Bye.